Hello, and welcome to this podcast. My name is Jeff Dunn. I am a pharmacist by training, have been in managed care for 25 years. I've worked at a health plan, IDN, and a couple different PBMs. I'm joined by Dr. Ed Pezalla. We'll introduce ourselves here in a minute. But what we're trying to do today is boil down 100 years of healthcare into 15 minutes. So we'll talk a little bit about the model and different lines of business and who does what and why they do it. Does that sound good?
That's terrific.
Okay.
And,
you will introduce yourself.
Yeah. So I'm Dr. Ed Pezalla. I'm a consultant in market access and other related issues having to do with things getting paid for by managed care and other health insurance companies. My background is in pediatrics, public health, and health services research. And I have worked in a couple of large payers in the U.S., most notably for Prescription Solutions, which was part of Pacific Care and became the basis for the PBM at United, and then for Aetna, where I was Vice President for Pharmaceutical Policy and Strategy.
Awesome. And Ed is well-respected, has been doing this for a long time, brings a lot of great experience and expertise to this conversation. So looking forward to the next few minutes.
Yeah, I've lost a lot of hair over all of this over the years.
Is that job related or just something else?
No.
Okay. Stress
it's
levels?
Job related.
Okay.
It's all about stress. That's right.
Okay. Perfect. So we're thinking maybe we could start with talking about lines of business, books of business, kind of where the autoimmune patient typically sits. Maybe you can start with that, and then I can talk a little bit about maybe health plans versus PBMs and some of the other stakeholders and how that all fits together.
Yeah, I think that's terrific.
Perfect.
So we have public payers and private payers here in the U.S., and it basically breaks down to the public payers are, for the most part, Medicare and Medicaid. Medicare is fully a federal program. It is generally for older persons, so age 65 and above. But there are people who are also in Medicare for other reasons, like end-stage renal disease or for severe disability. That's not a very large number compared to the number of people who are in Medicare just for age. Commercial plans tend to be focused on people who are employed and their families, and about 60% of commercial plans are self-insured, which will become important in a couple of minutes. That means that it is the employer who is taking the risk for how much everything costs, and the health plan, whose name is on your card, is basically just doing the grunt work of keeping it all running. 40%, though, is insured, which means that health plan is now taking responsibility for the risk as well. And then the other public payer is Medicaid. Medicaid is a federal state program, so it varies considerably from state to state. There are some federal rules. There's some things that are similar. But there is a lot of state variation, including the formularies, which are basically done per the state. And each state has its own rules about how formularies get created. Importantly, if you deal with pediatrics, a lot of pediatric patients are in either Medicaid or the related program, the Children's Insurance Program. And that's because they live in families whose incomes are near the poverty level in some sense, within 100% or so, or perhaps the whole family is in some other kind of plan, but the child is in the CHIP program for various reasons. They have their own sets of rules, but they operate in a way that's very similar to commercial plans.
Great. Thanks. The great overview. You mentioned risk a couple of times. So I think that is something we should talk about and understand. So what we mean by that is who is responsible for paying for healthcare, whether that's drugs or hospitalizations or whatever it is, whatever it may be. So taking a step back off of that is managed care and healthcare in the United States is extremely complicated. It's unlike the rest of the world where other countries have single payers, and it's a little bit more straightforward. Here, it's very siloed, not integrated very well. There's a lot of different types of payers. And I bring that up because I want to mention, again, just as a level setting, when a physician or somebody is working with insurance, they need to understand how that all fits together. So we have health plans, which are responsible for pharmacy and medical. Theoretically, that's kind of integrated, and they're working together. But a lot of times they will carve out pharmacy to what are called pharmacy benefit managers or PBMs, and they're responsible strictly or mostly for the pharmacy benefit. So how those get integrated can be a little bit of a challenge, but the goals are to provide expertise at driving towards the triple aim, which is improving outcomes, the patient experience, and lowering costs. But within that, there's been a lot of pressure in this country due to escalating costs, and not just drug costs, but escalating costs. And so ultimately, it comes down to the health plan or the employer who's using that health plan or PBM to pay for these things, going back to the risk issue. So it really is, as we're thinking about navigating the healthcare system, I think it's important, or one of my pieces of advice would be understand the money flow, understand where the risk is, and really who's paying for things. And then that kind of explains the behavior. But the challenge is we're kind of in our silos, and the goal would be to better collaborate and work together. And hopefully that's what we can talk about here for a few minutes.
Great. So when you're coming from a provider organization, a physician's office, a group practice, or something larger, an integrated delivery network or whatever it might be, basically you do need to understand something about where is that patient in terms of payment. Who is responsible along with the patient. Oftentimes patients have copays, to pay for that patient. So if they're in a commercial plan, then you mentioned already PBMs and the health plans, and theoretically they work together. And most of the time they're pretty good at putting it together. But you do actually have to know who to call. If you're going to have a discussion about what drugs that patient can be taking, should be taking, whether they're going to get paid for or not. And the general rule of thumb is that a drug that's going to be paid for by a PBM is on the pharmacy benefit, and that's usually a drug that can be administered by the patient. Now, maybe their spouse will help them or something like that, but generally speaking, it's going to be given by people who are not healthcare providers. If you're going to infuse a product, do an IM injection or something that patients don't do themselves, then that is going to be on the medical benefit. And of course, there's a big blurry line in between these things because we've all messed it up now. But and so you will sometimes see something that's used on the medical benefit, but it goes through pharmacy because they want to ship it to your office and that sort of thing. So a lot of things can happen there. But basically speaking, you need to have a general notion, is it going to be pharmacy or medical benefit? That has an impact on the patient's payment, their copays and things like that. But it also has a really big impact on who do you call to do a prior authorization, to ask a question, and things like that. And that's where you have to look on the back of the card, too. The back of that card says, well, for prescriptions, call, and it's going to be somebody. It might be somebody else. Now, there's a lot of integration these days. So I used to work for Aetna, and Aetna is owned by a big PBM, CVS Caremark, and so almost all Aetna plans will have CVS Caremark as the PBM, but not absolutely every one of them, because in some instances an employer has chosen otherwise.
Yep, that is great information and a great point. It's confusing because if you're a physician or a provider, and you're seeing a lot of different patients who have a lot of different types of insurance.
Yeah, absolutely.
So it can be extremely confusing. But again, just taking a little bit of a step back too, is what the PBM or the health plan is really charged to do is adjudicate that claim and manage the benefit as outlined by either the plan or the employer. So they're adjudicating claims, they're setting the formularies, they're developing prior authorizations, utilization management, they're potentially care managing. That's kind of what their job is.
Right.
And which overlaps a little bit with what the providers are trying to do, but coming at it from a different perspective. And so I think, again, that's an opportunity, but really, the challenge is understanding how to navigate that system from a provider perspective. So to your point, right, we need to really, the key is the data and being able to provide information to a payer so we can streamline that process and so we don't get into different levels of appeals and rounds and it can be really confusing because there's a lot of touch points.
That's right. And so it turns out, even though you might deal with several different insurance companies and maybe with patients for commercial and Medicare and, and perhaps you have Medicaid patients in your practice, eventually you're going to have interacted with all of those. And so keep some notes, of what happens here, and who's doing what and who does it for them. So like in your state, is there maybe each Medicaid plan has its own PBM that's doing things. But some states, they've consolidated it all under one PBM. And so knowing that can be really helpful because it's going to save you a lot of time later. So starting to get that little chart that you're going to need in your practice, because you're going to have a majority of patients are going to have just a couple of health plans. There's certainly going to be outliers here. But we also have to remember that for the most part, the big payers that you hear about all the time, Aetna, Cigna, United, you'll run into them all the time, but a lot of your patients are going to be Blue Cross and Blue Shield in your region. And we forget about that, but those folks, you need to know how they operate because you're probably going to have more patients in your waiting room that have Blue Cross than have Aetna at any one time.
And admittedly, this can be very frustrating. It's very complicated, and we understand that. But just want to point out that drugs are very, very expensive. It seems like every week we have a new $1 million drug. We have specialty drugs entering chronic disease states. If you look historically over the last 2 decades, drug prices in this country have doubled about every 4 years, and that's really not a sustainable model. And so what we're trying to do is thread that needle between outcomes and managing we have a fiduciary responsibility to manage costs. And so that's why unfortunately you see things like prior authorizations and step therapies. And just say those are not going to go away. But I think my piece of advice, building off what you said, is I think it's important to understand and potentially develop a relationship with the biggest payers in your region. Because if you have a conduit there and you have a pathway to talk, you can understand what the barriers are and what the issues are, and it's going to be easier to get through a prior authorization.
Well, and it also gives you the opportunity to go online or to look at their, fax things and get those forms. Pretty much everybody publishes their prior auth criteria. There's only a few plans that still don't publish. And so you can find out, well, what is it exactly they're going to ask me? And many times they have a fax form. I know faxes are pretty 20th century, but, we still use them. They have a form. Get those forms and take a look because they're very similar. And if you have all the information down, it's like, I need to know for this employer, this insurer, this company, how I'm going to request a drug that I normally use. Okay, so supposing you're asking for a particular JAK inhibitor and you want to get that, then those PBMs and health plans have published what's on the formulary, and they've published what their criteria are for the prior authorization. So you can write that down and say, well, now I know if I run into another patient from this plan, this is what I'm going to do. But after you've seen a few of these and you start putting them next to each other, you realize they're all very close. There might be nuances. Like one of them might say you need to have tried a certain other product for 6 months, and one says 3 months. So there are those differences and you can note those, but there's a lot of overlap, and this can make it a lot easier to get into that medical record and get all of that data. Because one of the first things, and Jeff and I will say this all the time, so I'm going to let Jeff say it this time. What's the major reason, Jeff, for something to be denied on the first request and overturned later?
Lack of information provided in the first round. So it's not a clinical decision or anything else. It's just the form may be not filled out correctly, or we may not have the information. So it's operational.
And that just costs you time and energy and makes everybody frustrated. And so if you can figure out what they're asking for in advance, and I think you will, I don't think it's that hard because you're clinicians, they're asking clinical data here. But you have to be able to go and find it in the medical record. And to be honest, we probably should modify some medical records to make a little form. So like, what is the stuff you need to know about this particular kind, especially because there are drugs that you're going to go to all the time.
And we talked about this before the podcast, and we don't really have time to talk about it right now. It might be worth another podcast, and that's technology and AI. And I'll just bring that up because that is a potentially really cool way to make this process a little bit more seamless. Mm-hmm. So I'm a little nervous about it, but I'm also optimistic that we can use technology to break down some of the barriers that exist in healthcare.
Right. Well, recently I was on a panel with a physician who is not in gastroenterology, but in another critical area of care where they request the use of fairly expensive medications all the time. And she said she was very frustrated about talking to health plans because you never got to talk to the specialist who actually knew anything about the care of the patient. You end up with a surgeon or a pediatrician or somebody else that you have to talk to about, a medicine in another field. And she felt like, gee, I'm just not really getting very far in discussions. But she was also concerned about AI. But I would suggest that in the future, if we have AI gastroenterologists, they might be a more fruitful discussion than talking to me as a pediatrician at a health plan, right?
Yeah, it'll be interesting.
Mm-hmm.
So to kind of wrap up, what would be your advice to a practitioner on how to better work with a payer?
Yeah, so I think, some of the things we've already said. Find out who the big payers are. I mean, it's really not hard. Talk to the folks in the business office. They know where they're sending their bills. And find out who the PBM is and who the health plan is for each one of those, whether it's Medicare and you're billing, a certain Medicare Advantage plan or a particular Part D plan. And remember that Part D applies even for patients who aren't in Medicare Advantage. And get their forms, just do it in the routine care. As each time I'm going to do a prior authorization, I'll just make some notes. I'll get the forms. Don't post them on the wall. It probably doesn't do anything for your decor, but hang on to those and start to see, well, what's the similarities? What are the differences? How would I know? So that's the first start, and the other is that really look at what they're asking and spend a little bit of time. Time spent up front means there's not going to be a denial because you didn't have the data that they were asking for. There might be reasons for denials that are other than that. There certainly are many, but don't waste time, your own time. Just take a few more minutes, get all that data in there. Much more likely to succeed.
Yep, that is great, specific and actionable advice. I think maybe I would just add something a little bit more obtuse or abstract, and that is kind of think about it from the other perspective. Put the other stakeholder hat on. And what I mean by that is as long as employers and health plans are the ones paying for these things, they're going to have to manage the costs. And so understanding that hopefully at least explains why people do what they do. It's not, it doesn't justify it, but it hopefully explains it. And so I think moving forward, the naive pie in the sky answer is, can we figure out a way we can work better together and share risk and share in the outcomes and the costs of managing these patients? If we could figure that out, we can get out of our silos. But the challenge is drug costs are not going to go down, even though we have biosimilars and everything else. Drug costs are still going to go up. And so utilization management is not going to go away. So I would just build on and reiterate what you just said is understand the process and really try to establish a communication channel with the biggest payers in your area. And that will eliminate a lot of the barriers, because once you get face-to-face and understand the process, things seem to go a little bit smoother. And then we can talk about things like gold carding and some of these other things where we can reduce some of the barriers once we're comfortable with the provider and how they understand what we're trying to accomplish.
Yep. So just we'll just try to get a little bit closer and talk. That's really what needs to be done. And as always, it's great talking with you, Jeff.
Thanks, Ed.